Kerry.
Thank you, my lady. Dr. Finnis, can I just pick up on one thing you told us about before the lunch break, which was you made reference to mask abuse. And I'd like just to have a look at one of the quotations that you've included in your statement. And could we call up on screen 409-574_23 and quote 13 there from one of your members that says they were taking their child to an appointment at Great Ormond Street, parked the car and was approached by a man and a woman who was shouting at me. They were really in my face and swearing. The man threatened to punch me up and then that he hoped our car would be all right whilst we left to go to our appointment. We were all wearing masks. The woman told us there was no need as we were all outside. And Maria, aged 39, felt under such threat that she called 999. And I just wanted to get a sense from you, if I may, Dr. Finnis, how widespread a problem was this? And is it still a problem now here we are in October 2024?
Yes, so I guess during the emergency time in the pandemic, it was less of an issue because obviously there were mask mandates and more people were therefore wearing masks. Certainly as that time's gone on, and certainly after Festival Freedom Day in 2021, and then which was the general removal or reduction of masks in society, and then 2022, June 22, where England removed masks from healthcare. After those two dates, wearing a mask has become increasingly concerning and worrying. Again, I mean, I do wear a mask everywhere, and I never know what kind of reaction I'm going to get. Certainly, I've been coughed on, spat on, that kind of thing, just out and about in shops or on public transport. Certainly, other CVF members report people forcibly taking their mask or pinging their mask. We've had people call us, sheep. Kind of a whole load of different things. I think that probably almost all of us have experienced now some kind of unpleasantness simply surrounding wearing a mask.
There's no accounting for some members of society who think that's the right way to behave, but I just wondered in part whether you think there is something wrong with the messaging, and that because although the emergency phase of the pandemic is over, clearly, indeed there's a variant, as we understand it, circulating now, whether the messaging has gone slightly awry in not ensuring that CV and CEV people are still at risk, and therefore there may be good reason why they're wearing masks. What do you have to say about that?
Yeah, absolutely. I mean, we do feel like we've just kind of fallen off the edge of the cliff, really. I mean, really, as far back as, shielding ended, I mean, none of us, don't forget, were ever told to what kind of mask to wear. There's never been any education or information or examples given to us or posted or anything like that. Those of us that do wear masks now almost certainly do have clinical vulnerability. One of the things that really worries me, and in fact it happened this morning when I was coming up on the train, I noticed two individuals wearing masks. Both of them, though, were not wearing them correctly. One was wearing what you would term a fabric face covering, and one was wearing an FRSM. And both of them were wearing under their noses. And it really, really affects me now because I really feel that people that are now wearing masks are probably clinically vulnerable. I'm almost feeling like I should have a stash of FFP2s with me that I start to give out to people because CVF's mission is still mainly online, but there is no public health messaging, information on the television or radio. There's no healthcare professionals that are informing people with clinical vulnerability and high risk to COVID that they are still at risk even. Unless you really understand the science or you're part of, for example, clinically vulnerable families or you've been warned by your physician, then generally speaking it's been minimised in all quarters of life, even in healthcare.
You mentioned a moment ago shielding stopping, and I'd like to ask you about that, please, in two respects. There was the decision to pause shielding, and then, of course, the decision to close the programme in its entirety. Can I just start with the decision to pause shielding in August 2020? And is this right, that CVF was of the strong view that stopping shielding in August 2020 was too early?
Yeah, absolutely.
And why are CVF and its members of that view?
Yeah, absolutely. So people who were, of much higher risk, and we've seen the increased death rates of these people, were suddenly in August 2020. It was literally like the withdrawal of suddenly all this support. So suddenly there was no access to supermarket slots. There was no access to help with going to the pharmacy. None of us were vaccinated at that time, right. And it coincided with Eat Out to Help Out. There was no public advice for people who were still higher risk at that time, that they were still higher risk. Nothing had changed in those people that meant that they were now lower risk. Although there was less current at that time in that part of August in the community, of course we know the story that happened, which is that the case rates rose again throughout that period. And shielding was not brought back in, I believe, properly until, I think, some tiers, because we went into tiers, and I think sometimes if you're in tier 4, you were expected to shield. I think for me that was kind of December, but I think formal shielding happened again in January 21. So for a huge period of time, clinically extremely vulnerable and shielded people really left their own devices without any help and support at all, either advice or practical support.
Now, can I pause you there? Because that might be a slightly different issue. The question I asked was whether you were of the view that it finished too early. The support provided whenever it finished is a slightly different question. But why is it that you say on behalf of CVF members that it was too soon to stop shielding in August 2020?
Because nobody had been vaccinated. Right. People were still the same high risk. Their condition hadn't changed. The virus hadn't changed.
Was there any consultation, as far as you are aware, or other CVF members before the decision in August 2020 to stop shielding?
No, I'm not aware.
Okay. And coming back to the support issue with whether it's stopped in 2020 and restarted, ultimately, I think it came to an end by July 2021. What consultation, if any, had there been before the shielding finished ultimately?
So there was no consultation with me as a clinically extremely vulnerable person that I knew of, and none that I know of within clinically vulnerable families either.
And again, support, was there any support in place for when the shielding programme finally closed?
No, none whatsoever.
And how did that impact the CVF members?
Well, all the issues that we've been talking about, such as difficulty with accessing healthcare, mask abuse, this personal responsibility, trying to rationalise the gov.uk advice, which is really all that remains with how we live our lives now, feels really impossible. It all comes down to this personal responsibility, which is what we've been told about. But we feel in CVF that it's really impossible to be personally responsible for some of these things because as I said, in busy A&Es, etc., it's very hard to, even wearing a good mask like I am, you're still at some risk without, for example, ventilation or testing. And indeed, many, many people who are not part of clinically vulnerable families don't understand how to wear masks, which mask and how. Clinically vulnerable families, I've done myself various videos trying to show people how to wear masks correctly and get the best fit. But it's really hard to get that information out there to everybody who I see on the streets, such as this morning.
You've mentioned the clinically vulnerable, and I'd like to just ask you a little bit about that. Clearly, we're aware that there was a different definition, and you've mentioned the absence of measures to protect the clinically vulnerable as opposed to the clinically extremely vulnerable. But I think it's right that CVF provided a degree of support to clinically vulnerable households. And if it helps you, Dr. Finnis, I'm at paragraph 89 in your report, but could you just help us with some of the measures that CVF have taken to support clinically vulnerable households?
Yeah, that's right. So just to be absolutely clear, though, about our definitions. So clinically vulnerable families represent clinically vulnerable households. Within clinically vulnerable households, there are clinically extremely vulnerable or shielded people and clinically vulnerable. So clinically vulnerable, if you like, is a bigger group, and then clinically extremely vulnerable and shielding is sort of a smaller circle within that group. So clinically vulnerable then encompasses everybody with higher risk. So So, as it says in the statement, that in 2020, Lara was able to draw on her expertise in microbiology, pathology and science to create a series of practical mitigations for children and school staff in schools, because I appreciate that's not what we're talking about here, but that was a real issue for our members at that time. There's also an easily accessible pinned post, which remains today within clinically vulnerable families that everybody can access. And we have thousands of members who can access this, which is updated to reflect the evolving scientific understanding. So what we're trying to do is to give people proper, decent, scientific information that we have translated for them so that they are able to be empowered to reduce the risk themselves and understand what their risk is, but also how to reduce it, what mitigations they need to take, and what is riskier than something else, for example. It's really hard to kind of be expected as a clinically vulnerable person to judge your own risk, the route of transmission, and how to mitigate against it.
Can I ask you about one of the matters that you raised there? And you say that additionally CVF was able to negotiate group discounts on essential products such as mask and air filtration units. Has there been any efforts to try and ask, I don't know, one of the departments or NHS England or anyone like that to help the clinically vulnerable negotiate discounts, given how much PPE they're likely to go through in comparison with someone who's not clinically vulnerable?
No, I don't believe we have actually asked the NHS, but we have written to the NHS about lots of things, as you might imagine, about healthcare. And to be honest, nothing's been extremely forthcoming about anything to do with clinically vulnerable people's safety within healthcare. So I would suggest that it wouldn't perhaps be very successful. In fact, we've just had to, right from the start of the pandemic, certainly from my own experience, right back to 2020, I've been having to work out which mask is the best mask for me, access them, buy them online, ditto air filtration units. I mean, we've got lots of information now, so we're able to advise people which mask might be better for them, depending on whether they're male or female, what kind of, as I said earlier, activity they want to do. And of course, air filtration units, we are in touch with one of the major providers of air filtration units. We're able to advise people of some charts that engineers have done, which shows us the size of HEPA filter that you need for the space that you want to clean.
Yeah, so I think you make the point in your statement that HEPA units for the home can be anywhere from £80 to £700, depending on the model and the size and the space that it's got to filtrate. Clearly, that's going to be a significant cost for most people, particularly at the upper end of that scale. And is there any financial support in place for filters such as those?
No, so the only support that we've managed is Lara's managed to negotiate a small, but we're very grateful for, air filtration unit from this particular company. But no, generally speaking, there are a lot of financial burdens actually on extremely and clinically vulnerable people, especially nowadays. Masks can be very expensive. I'm still paying between £35 and £50 for a box of 10 of these.
Is that per month, or would you?
Yes, it depends how quickly I wear them. But I have a child in school and I work, so I need probably one every working day at least. And then if I go shopping, so yeah, I need 2 boxes a month. Then I personally also have HEPAs in every room of my house because, as I say, I have a child in school. And it's not only having the HEPAs themselves, but obviously you do need to change the filter when that's right. It's totally worth it cost-wise for me. It's completely good idea, but you do have to factor that in. Many of our group now have got air filters. I think it's one of the commonest things that people have managed to put in place at home, particularly in those clinically vulnerable households where, for example, people may still be informally shielding, but their household members are going out to work in places like frontline jobs like hospitals or schools, and to have that HEPA filter in their front room is really helpful.
So that there's no misunderstanding about it, we know that CVF support the use of HEPA filtration in a number of different respects, but obviously most importantly in the healthcare systems And indeed, I think you make the point in your statement that there is NHS England guidance now on the use of cleaning air with HEPA, and you strongly support the rollout of that guidance.
Yes.
Just one other consequential cost that may get lost in this. I think you make the point in your statement that many CVF members now feel they've no choice but to access healthcare through private hospitals because they consider the NHS is unsafe due to the risk of hospital-acquired infection. And can you just help us? Have you got any sense of how many members are having to resort to private healthcare rather than going through the NHS?
Again, so when I did a thematic analysis of the group, it was certainly one of the dominant things that came about was certainly the financial burdens, and certainly private healthcare is certainly something. I mean, it depends if people can afford it or not, but I think generally speaking, if people can afford it, even if it's at the very ends of their affordability. For example, I don't know where it is, but within my statement there's a quote from somebody who I think took out their pension funds to...
There is, pause there, Dr. Finnis, because there's two quotes on that page. Can I go to INQ 409574_66? It may not be the pension quote, but I've seen that one as well. But there's a quote here at 57 from a CVF member. Ooh. Thank you. I took early retirement, so my private health insurance stopped. I decided to pay myself, which this year was over £6,000. It's a very heavy financial burden. In 2021, I had to have a new heart valve and pacemaker, and I simply would not risk an NHS hospital. And they say the special measures the hospital took were brilliant. They've had hand surgery recently too, limited contact, private room, personalised treatment, i.e. they wear masks on request. I presume they mean staff there. No crowded waiting rooms, makes it worth it to me. Of course, private health does not cover chronic conditions, and NHS hospitals and waiting rooms continue to frighten me, so I minimise attendance. And you're right, there are other examples you give in your statement of the financial burden it places on people. Can I just ask you two final matters, please? You set out in your statement anecdotal evidence that CVF has gathered in relation to the use of DNA CPRs and concerns about blanket use and otherwise of those. And that's at your paragraph 112 onwards, Dr. Finnis. And I think there is concern, is this right, amongst CVF membership, there may have been DNA CPR orders placed on those that are clinically extremely vulnerable or clinically vulnerable as well. I wasn't clear which.
I mean, we don't know. Okay. I think that's the important thing to say. But from the people who do know, because obviously we don't know how big the problem is, but we do know that a fair number of people who were shielded, so clinically extremely vulnerable, were either approached during that emergency part of the pandemic in a way that they wouldn't have expected to have been done just, the day before that started, to ask whether they want to be resuscitated. And indeed, there's quite a few examples of, relatively young people in their 30s, 40s and 50s who have been either asked that question or have found it on their discharge letters when they come out of hospital, having it not being discussed with them at all and it being a real shock.
Yeah. Okay. Final topic, please. We've, during the course of your evidence, looked at a number of recommendations that you would urge Her Ladyship and the inquiry to consider. But one of the matters you raise in your statement is you say there needs to be better identification of vulnerable people based on early scientific evidence, and there needs to be good communication to people at high risk with information on how to reduce their risks. And I just wondered whether CVF has any measures to propose to help identify this group or these groups of people in the event of a future pandemic.
I think we would support Q-COVID. I think that any developed algorithm which is specific to the illness brought about as quickly as possible. I think in the meantime, though, you make your best guess, if you like, from, as they said, from the science that's coming out of the other countries to decide. I think the important thing, though, is that it's about not only who you protect, but how you choose to protect those people. So, for example, rather than going sort of straight into shielding, you do give people that proper information about potential modes of transmission, how to reduce the transmission, whether masks work or not, or whatever it might be for that particular infection. and to actually give people that passporting to enable them to work from home, to support the family, so that they too can work or be at home too if needed. I think it's about empowering people that's important.
Dr. Finnis, that's all the questions that I have. I know there are some other questions from core participants. Thank you.
Mr. Weatherby.
Good afternoon, Dr. Finnis. I'm going to ask you a few questions on behalf of COVID-bereaved Families for Justice UK. And I think that's an organisation you know because they've done joint work with you and your organisation. Just a few questions picking up some of the points that you've already touched upon. Can I start with the issue of DNA CPR orders? In your statement, you expressed the deep concern, I think the term used is very concerned, the deep concern of CVF about what you describe as the discriminatory and inappropriate use of such orders. For the record, it's paragraphs 1, 2, 2 to 3. Now, we know that in the report of the inquiry experts, they say the following, that a DNA CPR notice is not meant as a proxy for broader treatment decisions. However, in the absence of clearly documented discussion and decisions about other forms of treatment, there's a potential for inappropriate overinterpretation of DNA CPR as a generalised treatment limitation option. That's at paragraph 40 of their report. And they go on and they say, and again I quote paragraph 49 of their report, when DNA CPR is the only documentation of any form of treatment limitation, it also may open the way for potential misinterpretation of DNA CPR as a general indication of poor outcomes or a decision to restrict other treatment options, which is not its intended purpose. Now, sorry to read out two long passages to you, but you refer in your statement to mission creep. Mm-hmm. So first of all, do you agree with the observations that I've just read out to you from the experts?
Yes.
And do they, in fact, resonate with the views that you've expressed?
Yes, definitely. And I think clinically vulnerable people, some have experienced that, but also would be very worried about that still being left on people's records, and
yes.
that would mean that they wouldn't be able to access some other treatment other than resuscitation. Yeah.
In terms of mission creep, are you saying that there's a concern about a tendency for such orders to lead to the exclusion of clinically vulnerable people from other life-saving treatments?
Yes.
Thank you. In terms of the decision to end or to pause shielding, and you've been asked about the initial pause in August 2020. And in fact, paragraph 62 of your statement, you refer to this as being like falling off a cliff. And you've told us about one of the concerns was that this was pre-vaccines. Apart from the fact that you and CVF believe that this was far too early, is another concern that it should, whenever the appropriate time was, that shielding should have been reduced by stage. There should have been a stage reduction rather than a blanket reduction. Is that right?
Yes.
And part of that would have involved a more nuanced risk assessment approach, accompanied by ongoing support.
Yes, absolutely. I think one of the difficult things was when we fell off a cliff, as you say, there was no information about how to manage your own risk, identify your own risk even. And there was no offer of any psychological support either. Right.
My next question is about support. And you've already told us that there wasn't any. But in terms of transitional support, first of all, in your view, should it have been vital that there was support once there was a step down from shielding?
Yes, absolutely. People have been locked and, really traumatised by these constant text messages, letters and emails that they're going to die if they step outside their house. It never happened before. It was extreme.
Yeah.
And they just literally left us.
Yeah.
And I think, to have had an offer of transitional support with other parts of support, such as psychological support,
Yes.
Would really have helped.
So psychological support, proper information, perhaps ongoing food parcels, that kind of
certainly
thing.
supermarket delivery slots,
Yeah.
I think, by that point. And obviously, collecting things such as pharmacy prescriptions.
Yeah, and maybe financial support too.
Financial support. Yeah.
Now, you talked about the necessity for the provision of information to clinically extremely vulnerable people in these circumstances. But should the pausing or ending of shielding programmes have been accompanied by a wider public information campaign to educate all of us, employers, schools, other organisations, of the ongoing risks to people who are clinically vulnerable? And would that have been something that should have been put in place?
Yes, please. I think we would, that's what clinically vulnerable families would say. I think that's been one of our problems, is that we've been really left to fend for our own rights, but also advocate for the risks that we still face in all of those places, such as schools and healthcare, even despite the gov.uk, which tells us to take all these precautions.
Yes.
We simply cannot, without any understanding on behalf of the employers or the organisations.
Yes, thank you. The only other question I had has been covered certainly in part, which is about the healthcare position, the lack of provision in healthcare for clinically vulnerable and clinically extremely vulnerable people, both at the outset and ongoing. As a medical doctor and a spokesperson for CVF, isn't this something that is really very obvious? Isn't this something that should have been planned for and should still be obvious, that if there's a whole section of the population who are particularly vulnerable, then measures need to be put in place?
Yes, absolutely. I mean, CVF would, absolutely. It just seems like we've been completely left to our own devices, only personal responsibility, as I say. There is still no obvious measures, as you say, that should be infection prevention and control in hospitals.
Yes.
Or any part of healthcare, actually, GPs, etc. too.
Yeah, GPs perhaps.
Yeah.
Very importantly.
Yeah.
Doctor, thank you very much.
Thank you, Mr. Weatherby. Thank you very much indeed, Dr. Finnis. I'm so sorry to hear about what's been called mask abuse. And it sounds like such a trivial term, but I can imagine just how distressing it must be for people like you and your colleagues to receive such abuse. I'm afraid the toxicity of some people never ceases to surprise me. But anyway, thank you very much indeed for all your help. I'm very grateful to you. And just one question, how do you manage to avoid COVID when you've got school child or children?
So my child, we've actually managed to get HEPA filters into all the classrooms, and the school are really good at telling us whether there's a COVID case. So it just proves it can be done.
I was going to say, I find my grandchildren the biggest vectors of any disease that's going around. Anyway, thank you very much for all your help.
Thank you.
Thank you, my lady. The next witness is going to be taken by Mr. Fireman, and there'll just be a pause while we allow Dr. Finnis to depart.
Please call.
Sorry, if we can, someone's talking. I don't want the oath taken while someone's talking. Thank you.
May I please call Dr. Bryden?
I do solemnly, sincerely and truly declare.
I do solemnly, sincerely and truly declare and affirm
That the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Dr. Bryden, I hope you haven't been waiting too long.
Thank you.
Your full name, please.
Danielle Claire Bryden.
You have, I hope, a witness statement in front of you.
Yes.
That should be INQ 30389-244. That is dated the 18th of December 2023.
Yes.
Dr. Bryden, you are the Dean of the Faculty of Intensive Care Medicine, is that correct?
Yes.
And you have attended today as a witness on behalf of 3 organisations: the Faculty of Intensive Care Medicine, the Royal College of Anaesthetists, and the Association of Anaesthetists, I'm sorry.
Yes, that's correct.
Are you able to provide us with a bit of background about each of those organisations?
Yes. So the Faculty of Intensive Care Medicine is the UK professional and statutory body for the medical specialty of intensive care medicine. The Intensivists, the Advanced Critical Care Practitioners and the Critical Care Pharmacists, and has around 4,500 members across the UK. The Royal College of Anaesthetists is the UK professional and statutory body for the medical specialty of anaesthesia and has a combined membership of more than 24,000 fellows and members. And the Association of Anaesthetists is a professional organisation made up of over 10,000 anaesthetists in the UK, Republic of Ireland and internationally.
Thank you very much. Dr. Bryden, I'm going to ask you about the following today. First of all, I'm going to ask you a bit about your organisation's involvement with senior decision makers. I'm then going to ask you a bit about infection prevention and control measures. And I'm then going to ask you a bit about critical care capacity, then redeployment, and then a bit about the impact of suspending elective care. Is that all clear?
Yes.
Can we turn, please, to the first of those topics? Is it correct that your organisations were collectively and individually involved with regular meetings with NHS England and the Chief Medical Officers?
Yes, that's correct.
And you described various topics within your witness statement that you discussed with them. One of those is the need for clarity around PPE requirements. Can you recall what the specific concerns that you raised in terms of availability of PPE were with the NHS England medical director?
I am aware that our organisations at the time had 3 broad levels of concern. Early on in the pandemic, it was around the provision of advice and the timeliness of the advice as to the correct PPE to wear, because we were aware that many of our members and fellows were looking to us for distillation of that advice, and we were struggling to be clear as to what that advice was. We then also had concerns around the consistency of the advice in terms of the timescales and, again, what PPE individuals should wear. And then finally, there were concerns as later on in the first wave around the availability of PPE and the appropriate PPE.
And can you recall when, what sort of time frames you raised these particular concerns?
There were, at the time, in the first wave of the pandemic, there were regular meetings with both the Chief Medical Officer and the National Medical Director's Office. Those meetings went up to twice weekly in frequency. I do not have a specific date for you, but I can get that information for you if you require it.
Do you know broadly what response you received to each of the concerns you raised before?
I know early on in March, sort of in the first week of March, it was very much around highlighting the need for the clarity of information, and we were made aware of the fact that that the correct information was expected, but we were not in receipt of information as to when we could expect it.
The inquiry's obviously heard, and this is the next topic really, which is linked, which is infection prevention and control measures. And the inquiry's heard a lot of evidence about the availability of PPE, as we were just talking about. You raise in your witness statement a particular concern that you were getting from members, and given the nature of the role that your members do, you talk about availability. And so I was going to ask you, is that about availability of respirators, or is that about gowns or any particular PPE that was not available to healthcare workers?
So The first wave did not impact equally on all areas of the country, and we were getting reports from different groups of individuals around the availability of suitable PPE in terms of gowns and visors that were both clean and appropriate for donning and doffing, that is, taking on and taking off in a safe manner. And then there were also concerns around the FFP3 masks and being able to have the appropriate FFP3 masks to be fit tested to our members and fellows. So there was a heterogeneous response to the fit testing. Some individuals were fit tested, some individuals were not fit tested, and there was different PPE availability at different times. So individuals were reporting the fact that they might have been fit tested for a mask one week that was not then available to them the next week or a short period after. And it became a situation that people were identifying concerns around using PPE that they had been appropriately fit tested for, and also some people having a concern around appropriate PPE that was clean and safe to use.
So,
These
sorry.
concerns, forgive my interrupting, relate just to England, or did they relate to Scotland, Northern Ireland and Wales? Or any of the three?
Because the pandemic effectively came through the southeast initially, most of those reports in the early phases were around what was happening in the southeast. But obviously in other parts of the country, people were aware of what was being reported in the southeast and had concerns, therefore, that we were needing to conserve PPE and manage it in a responsible fashion. So that then influenced thinking around availability of PPE and how it should be used.
Did you also have concerns about the effects of using PPE?
I'm sorry, I'm not
in terms
catching.
of the effect that had on healthcare workers and some of the side effects of using PPE?
I was not aware of any concerns at the time around the effects of using PPE. People wanted to make sure that they had PPE that enabled them to do their job. But I think as the pandemic, particularly that first wave, developed, the problems of wearing PPE for long periods of time became more apparent, and the impact that was having on people doing their actual activities became clearer.
If we could go to your witness statement, and this is paragraph 180, it might help to get this on screen. There's some quotes here, a series of quotes that I understand are taken from the Association of Anaesthetists as part of their series. If we just look at this second and third one, we can see here when we first started treating patients, we were only allowed surgical face masks. The evidence from Italy at that time was to beware the patient who had tested negative. I'm sure that there were members of staff who became infected due to not being allowed the appropriate level of PPE. We did have enough PPE most of the time, although FFP3 masks were rationed to a degree. It carries on. And then the next one, the one underneath that, says, I remember the sound of my own breath in my ears, amplified by the respirator. I remember swearing under plastic PPE. Sweating, sorry, thank you. Sweating, important clarification there. Sweating under plastic PPE and viewing the world through a smeared visor. I remember struggling to recognise colleagues under their PPE or understand what was being said. It made everything harder. So just what I wanted to ask you about was those two quotes. Are they essentially the two sides of the concerns around PPE? On the one hand, a concern about not being able to use it, and on the other hand, a concern about the effects of having to use it?
Certainly the second quote I very strongly recognise personally, and also in terms of people's experiences of working for long periods of time in the PPE and the difficulties that imposed. I think in the first quote there was a lack of understanding initially on wearing PPE outside of the areas where it was known that there were aerosol generating procedures. So I think there was an understanding from the get-go that intensive care units were going to be areas that had aerosol generating procedures and people needed full levels of PPE. But there was perhaps less clear understanding about other areas of the hospital and what PPE was required.
That's in a related topic, something that you touch on in your witness statement in terms of the difference between aerosol generating procedures and other areas. And some of the points you make, in fact, include that there are some downsides of designating areas as aerosol generating areas or aerosol generating procedures. Is that something that was of concern to you and your organisations?
I think we, at the time, were very concerned, particularly with the evidence that was coming from China and India, that both individuals working as anaesthetists in a theatre complex and intensivists working in an intensive care unit were going to be working in areas where there was a high risk of aerosol generating procedures. So there was an understanding from all our members that they were going to be at particular risk, and therefore there was concern around having appropriate PPE.
You also cite in your witness statement a study from early in the pandemic. It's paragraph 291 if you want to refer to it, but essentially it's a study of 119 healthcare workers who died, and in it you note that there were no intensivist and anaesthetist deaths, and there are a number of reasons that you've provided for that, which include higher performing PPE amongst other reasons, including the stage at which patients in intensive care are treated in terms of the development of the virus. Do you recall that study?
I'm afraid I'm not.
If we could
able
put it
to
on the
access.
screen, it's paragraph 291 of Dr. Bryden's witness statement. You should hopefully see there that there is this cited study.
Yes.
And then there is a series of reasons as to why it may have been the case that intensivists and anaesthetists died at lower rates, or indeed not at all in this study.
Yes.
This was something which was asked about from the infection prevention and control perspective with Dr. Ritchie of NHS England. But from your perspective, can I ask you whether or not you felt that healthcare workers working in intensive care felt that they were better protected by using respirators?
My recollection at the time was it was not a question of feeling better protected. It was around having the necessary equipment to do the role and the job that was required of you. And we knew working in an intensive care unit was an area where there was going to be a lot of aerosol. So effectively it was around making sure staff were appropriately protected with the equipment they needed. It wasn't about necessarily a comparison against other areas. It was about having the right equipment for the job you were doing.
So when what you quote in your witness statement, where you say higher performing PPE, just to be absolutely clear, do you mean respirators there?
Intensive care staff were wearing FFP3 masks, visors in the first phase of the pandemic, gowns and gloves. Individuals who could not find an FFP3 mask that would fit them appropriately were very often provided with a respirator type system.
Sorry, I'm including within respirators a respirator mask.
Yes.
My apologies. That can come down. Turning then to a different topic, the next topic, capacity. And this is, when I say capacity, I mean here critical care capacity. And you describe in your witness statement that in early 2020, some clinicians were concerned that services would be overwhelmed, as was the case in terms of the scenes that were seen in North Italy, and that there was a desire for additional triage guidance. So are you aware of that?
Yes.
You then describe, this is at paragraph 49 of your witness statement, that the Faculty of Intensive Care Medicine were involved in drafting a guideline which they co-authored with NICE, which I think is NG 159. We'll get that up on screen in a moment, but can you explain, first of all, what the purpose of creating a new guideline was at the outset of the pandemic?
Yes, so the Faculty of Intensive Care Medicine was one of the organisations that was co-opted to the NHS England Critical Care Clinical Reference Group. And the Clinical Reference Group discussed areas of support that were going to be needed for hospitals as the pandemic was approaching, or as patient numbers were perceived to be increasing. And the concept really was around, after discussion in the clinical reference group, having some form of document that would support clinicians in making usual clinical decisions in extraordinary circumstances. So the perception was that the NHS England Clinical Reference Group would work with NICE to produce a document that would support the clinicians. And from that initial, if you like, scoping exercise, a document was produced, which became the NICE guidance, NG 159.
You make clear in your statement at paragraph 55 that this guidance wasn't ethical or legal guidance on how to triage patients in the event of saturation of critical care capacity. So in those circumstances, why was a new guideline, as opposed to the ordinary principles of determining whether someone is appropriate for critical care applying, why was a new guideline necessary?
So if it's okay to put some context into this. So approaching that first wave of the pandemic, the thinking very much was we would have our normal critical care patient workload and we would have an additional COVID patient population of an unknown size. And critical care teams often provide support to ward teams and patients in terms of providing support and advice and helping them to help patients make a decision about if they deteriorated, if they would want to come to critical care. Our understanding was that with this increased workload and the need to bring more of intensive care staff back into the building, if you like, the intensive care service to support patient care, we were going to be less able to provide that historical degree of support. So the focus very much was around giving ward teams the ability to be supported, to have important conversations with patients that were coming into hospital at the earliest stage possible, and to allow them to contemplate what they would want for their own treatment. So the idea was very much around giving patients an understanding of what was involved and an ability to express their views whilst they were still able to do so.
So if I understand what you're saying correctly, is it then a case of having a discussion that would ordinarily take place later on in the pathway, earlier on?
Yes, it was about having an earlier discussion and giving individuals who perhaps wouldn't routinely have these discussions a degree of ability and a toolkit of resources to enable them to have those discussions.
If we could look at the first iteration of that guidance, this is INQ 30474-301 and page 2. This is the iteration that was published first on the 20th of March 2020. Yes, I want to look at that first section. So it says admission to hospital. On admission to hospital, so just pausing after that first comma, is that on admission to hospital the distinction between what was involved previously and what is now the starting point of this guidance?
Yes, NICE had identified with the clinical reference group its plans for producing information to support clinical teams, and we were advising them on this document in terms of an additional piece of information to help.
What would happen in a scenario where someone was admitted to hospital and it was deemed that they were not appropriate for escalation to critical care?
I'm sorry, in normal circumstances or?
In normal circumstances, I understood from what you were saying that generally at the point of referral to critical care, that's when you would decide whether or not someone was appropriate for escalation to critical care. What about in circumstances where the guidance is telling us that you need to make a decision about whether someone's appropriate for critical care at the point at which they're admitted to hospital? Does that change in any way the patient experience?
So I think it's important to go back to the fact that this is actually not making a decision in isolation. It's about involving patients and ideally their families in normal circumstances in the decision-making process about what they want for their care and their treatment and whether or not they want escalation of care. So it's very much focused on making sure that patients who, particularly when the capacities, have the ability to identify what they want for their treatment. And often in intensive care, a situation can sadly arise where an individual may deteriorate very rapidly and that conversation has not been explored with them and those views aren't known. But this was about saying when a person comes to hospital, it's really important to involve them in the plans for their care and the discussions around what they want for their treatment at the earliest possible phase, because we were not aware of how their condition was going to then subsequently be managed over the
inquiries,
course of the
sorry to cut across you, but the inquiries had a lot of evidence about the difficulties of having conversations with patients and with their families within the context of the pandemic. Was it possible, do you think, to have these conversations at an early stage?
We, as the Faculty of Intensive Care Medicine, have been trying to support individuals and families to contemplate what an intensive care admission means for a long time before the pandemic. So we had produced documents to enable individuals to consider that and other hospital services to consider that. For us, the perspective was very much on not missing the opportunity to have this conversation with somebody because it was an important conversation. So it was about making sure that that attempt was made and to try and have that conversation rather than to leave it to the point where it was going to be impossible to have that conversation.
Can I ask you about the second part of this sentence? It says, on admission to hospital, we've looked at that, assess all adults for frailty, irrespective of age and COVID-19 status. And then it goes on to recommend using the clinical frailty scale for frailty assessment. Is it right that the clinical frailty scale is not appropriate to use on people who have long-term stable disabilities or are under 65?
Yes, that's correct. It's not been developed for use in those groups.
This guideline didn't make that clear, did it?
No.
Why was this omission allowed to come into the published guidance?
I do not know. As I said, we provided advice to NICE in the drafting of it. I do not recollect ever having a conversation in which we were specifically asked about particular groups of individuals, but obviously we would be clear about where the frailty scale had been validated and who it was intended to apply to.
Sorry, just to clarify, I thought that the Faculty of Intensive Care Medicine co-wrote this guideline. Is that not correct?
We provided advice with the chair of the clinical reference group to NICE. NICE wrote the guideline and we provided advice to them and input to them around the writing of the guideline, but the final decision around the format of the guideline was NICE's decision.
The inquiry understands there was then some correspondence with various groups, including, I think, MENCAP, on behalf of learning disability, people with learning disabilities, and the guideline was then amended. If we could then have a look at that amended guideline, this is, and we might be able to put it on screen as a comparison here. It's INQ 303155780. So here we go. This is the amended version. So we can see here there is a series of further caveats now in terms of how to use the clinical frailty scale. In particular, the second bullet point, it should not be used in younger people, people with stable long-term disabilities, for example, cerebral palsy, learning disabilities or autism, and individualised assessment is recommended in all cases where the CFS is not appropriate. My question really is just a similar one, but it's right, isn't it, that the first iteration should have included all of these caveats?
Yes.
Thank you. That can come down.
If I could also add to that, I think it's also important to make the point that people should be helped to have the conversations that are are required and have given the support that they need to have those conversations. And that's something that we always have tried to do within intensive care medicine. So it was not a change in our practice that we would have not looked to try and provide support to individuals to help them make a decision. That was not intended to change.
You made clear earlier that this guidance, it's not guidance designed to be used in the event of a saturation of critical care resources. I've been asked to ask you by one of the core participants whether you think that directing healthcare professionals to the clinical frailty scale without caveat in the beginning could have encouraged rationing of care on this basis and indeed the use of DNA CPRs because people were scoring poorly on the clinical frailty scale.
Our intention and our advice was very much around helping as many people as possible to be given the information they needed to make a decision about their care and treatment. And bearing in mind we were looking at a large number of people who could potentially require intensive care treatment at a time in the pandemic when there was no other treatment that impacted on the course of COVID or the outcome from COVID. All intensive care treatments at that time were supportive and didn't impact on what the disease did to the individual, and all of those supportive treatments had an associated morbidity and harm in themselves. It was really important to make sure that as many people understood what an intensive care admission involved as possible to allow them to be clear about whether or not they wanted to have that and contemplate that.
Do you see any connection between critical care capacity and decisions about escalation of critical care and the use of do not attempt cardiopulmonary resuscitation orders or notices being used?
Do you
see any link between capacity pressures and the increased use of DNA CPRs?
So what we have always known historically in intensive care is that when we have less resource available, our ability to take patients who need monitoring is impacted, but it doesn't actually impact on the decisions that individuals make about whether an individual should come to intensive care. And as our organisations were clear throughout the pandemic, we emphasise the importance of using normal ethical decision-making principles, which does involving patients. So we know when resource is impacted, the ability to take people to monitor them is reduced, but the actual behaviour in terms of the conversations and the ability to offer treatment should not be impacted, and we made that very clear to our members throughout.
So presumably that includes the use of provision of CPR, for example, if appropriate? Well,
we would have discussions around CPR in intensive care with individuals, but usually discussions around CPR on the wards are often conducted and led by ward teams.
Can I ask you about the concept of a prioritization of critical care tool in the event that critical care capacity is reached? You acknowledge, paragraph 58 of your statement, that the lack of a national prioritisation tool, in other words, a nationally or government-endorsed tool to tell clinicians how to assess patients in the event that they had to make decisions about triage because of resources, the lack of that tool left some working in intensive care feeling vulnerable and exposed. Is that right?
Yes, our members were clear that that they were concerned about what happened if resources were significantly impacted and they could no longer do what they normally did, which is use their normal ethical and decision-making processes, and what the position was going to be under that circumstance. So there was a concern that that situation might arise, most predominantly in the early phase of the first wave of the pandemic, when people didn't have the experience that they subsequently had.
The Intensive Care Society created, or indeed published after some amendments, its own tool, which may have been based on the national prioritisation tool which didn't actually make its way into formal guidance. Is it right that your organisations didn't endorse any prioritisation tool in the event of critical care capacity being reached?
We did not endorse any prioritisation tool. As I said, we were clear to our members that we wanted them to continue using their normal decision-making processes, and we were also very clear and consistent in our position that if a tool was going to be developed, it needed to be developed by an organisation like NHS England or NICE and actually have wide buy-in from multiple stakeholders, and that was the position we maintained.
Why? Why does it need to have endorsement from NHS England or NICE? Why couldn't an organisation within the intensive care sphere have published their own guidance?
I think the fundamental intention of guidance is to help individuals, but we were very clear that there were a number of issues around a single organisation producing guidance, not the least of which is the importance of guidance being able to respond to the change in the knowledge base and the information, being able to monitor and change that guidance appropriately, to have the appropriate consultation and understanding of all endorsing organisations, and to also have a wider involvement of the public and an understanding that this was in place. We also took a view that as the pandemic went on and treatments changed and our understanding of the disease process changed, our understanding of the need for triage guidance again altered, and we felt that it wasn't appropriate at later points to have that kind of guidance because we had different ways of managing the system when it was under pressure.
Sorry, so just could you clarify, what is it about it being endorsed by a government agency or from the Department of Health that you felt was particularly important, as opposed to just the general difficulties, which there may well have been in producing this guidance in any event?
I think if I can go back to the NICE guidance, when we were advising NICE, we had actually identified with NICE that we felt at that point that we wanted something to go into the guidance to say where to look for guidance if the system became overwhelmed. But that piece of advice that we gave was never produced into the final document. But our view very much was it needed to be a four-nation type approach in order to be fair. There were issues around equity, concerns around the fact that we didn't want one part of the UK to be triaging patients and, if you like, not admitting people to intensive care while other patients had the ability to do that.
Can I ask you about that particular point? Because it's something which you note in your statement about the potential variability of ICU capacity amongst, but within England and also across the UK. But would it not be the case that a tool or a prioritisation guidance would only come into place once all options had been explored, such as mutual aid, critical care transfers? So would it not be something that would be in place to only be used if, in fact, capacity was reached in all senses and you couldn't transfer patients somewhere else, for example?
Well, our view very much was that there needed to be a clear instruction to embark on that kind of activity, and that really needed to come from a central organisation, and that it did need to have a wide endorsement so that people were understanding why this activity was taking place. And that's why we took the view that it needed to be a central organisation that took ownership and leadership of this. We were consistent in that view throughout.
The inquiry has obtained a series of spotlight witness statements from various hospitals across the United Kingdom, some of which I hope you've seen, and some of these hospitals produced their own prioritisation guidance to guide their own staff as to what to do in circumstances where critical care capacity was reached. Have you any views on the fact that there were potentially different tools being produced by different organisations, and are there any risks in that occurring?
I think it's difficult to comment on any particular validity of the tools that you've asked
Just
to
generally,
look at. But in generally, I think our view very much is that kind of activity developed probably because there was an absence of nationally agreed guidance, and that people with the best intentions were trying to develop a tool in case it was needed. But I haven't any particular knowledge. We haven't any particular knowledge of why certain tools were developed. Our view very much was that there needed to be a consistency, and then there needed to be a common shared understanding of what was going to be done and who was going to be responsible for that.
So can I ask you this then? Is it the case that what you're saying is that it's not that you don't support the production of a critical care prioritization tool, it's that you think that any such tool should be endorsed by national bodies? Is that right? Or did you not support during the pandemic the production of any such tool?
So going back to that first wave in that first phase, that's when the fear amongst clinicians was greatest because of what people had observed, particularly in Italy 2-3 weeks before. So that was the point, if you like, of heightened anxiety. But inevitably, as that experience developed in the first wave, people's clinical experience improved and their confidence improved. And obviously, by the time we got to the second wave, we had different ways of managing patients with COVID. We had much more effective use of mutual aid in terms of transferring patients. It went from a situation very early on of a fear that such a tool might be required to an understanding that the baseline had changed and it was not required. At that point, there was an understanding that it might be required at a future point, but we had other options, clinical options available.
Can I ask you from a different angle, do you think then practically and in reality that everyone who needed intensive care during the relevant period received it?
I am not able to comment on that because I don't have the data and I don't know about that. But I can say from our organisation's perspective, we were consistent throughout the pandemic that we said to people, our members and fellows, use the normal clinical and ethical decision-making processes and continue to do what you normally do.
So did you receive reports from your members or from members of all of the organisations you represent to the effect that they were having to take any decisions about who to prioritise based on resources?
As far as I am aware, the concern, particularly in that first phase of the pandemic, was around whether or not there was a tool that was being supported by a central organisation and whether or not that tool should be used. So I am personally aware, having been contacted via WhatsApp from a clinical lead in another area who sent me an early copy of a tool, and the question was, are we meant to be using this or not? That there was confusion to a certain extent about whether or not there was a central tool being provided.
Thank you. My lady, I'm going to turn to another topic, so it might be an appropriate time to have a 10-minute.
Certainly, I hope you're all warned about our breaks, Doctor. I shall return at 3:25.
All right.
Mr. Farman.
Thank you, my lady. Dr. Bryden, I want to turn to a different topic now, which we foreshadowed earlier, which is redeployment. And can I ask you about it both from the perspective of anaesthetists and also intensivists, because I understand your organisations represent both of those professions. With respect to anaesthetists, were the majority or a high proportion of them redeployed to intensive care units?
it's important to consider the various phases of the pandemic and the involvement of our anaesthetic colleagues in supporting intensive care units. All intensive care, all anaesthetists do some intensive care medicine training, and certain hospitals at times of particular pressure and at certain points of the pandemic will have had support from anaesthetists to provide additional input into the critical care unit. We don't have a specific number of people who were redeployed at any one particular time, but there are a number of surveys that were conducted, particularly those by the Faculty of Intensive Care Medicine and the Royal College of Anaesthetists, which give, if you like, overall figures as at certain time points as to how many people identified as being redeployed.
So just generally speaking, during the peaks of the pandemic, were anaesthetists going to intensive care units in higher proportions than they would normally have been?
Yes, absolutely. Normally, we would say that of the intensivists who have anaesthetic training, about 50% of intensivists have some anaesthetic training. All of those will have been brought back into the intensive care full-time, and then in addition, additional anaesthetists will have been brought in to support local services as and when required.
In terms of the experiences of those anaesthetists who were redeployed, do you know and are you able to summarise whether or not the experience was positive or negative or a mixed experience?
I think it would be fair to say that we would not have been able to deliver what we did without the involvement of our anaesthetic colleagues, but that came at a burden, a considerable burden to them. Some reported in our surveys that they found the experience helpful and useful, particularly around maintaining skills, closer working with intensive care colleagues. Others found it very difficult and very stressful working in an intensive care unit after a period of time. So I don't think it would be possible to say there was a uniform experience. It was very personal.
Of course, that makes sense. But focusing, well, one can understand why it may be potentially harrowing for some people to be involved with intensive care in circumstances where they hadn't previously been. But focusing on some of the positive aspects of redeployment, and you talked about the skills that were learnt, is there anything that we can learn about the fact that those staff learnt new skills by being in intensive care, about how we could best prepare for the potential need to redeploy staff again? Is there anything we could be doing in non-pandemic times to enable the transition to intensive care to be easier?
Yes, and if I can provide a degree of context. So prior to the pandemic, the Faculty of Intensive Care Medicine had done some work on the development of an enhanced care service. This was around supporting patients on elective care pathways who didn't need a full intensive care admission but needed more treatment and care than could be supported on the ward. And that service could be managed by our anaesthetic colleagues. And again, our anaesthetic colleagues were very supportive of the concept of trying to provide more for patients on the perioperative care pathway, because a lot of them do work in perioperative medicine. These kind of reservist skills, as we identified and called them, were a way of saying people could be involved in aspects of care for patients that were more than they might ordinarily have done before the pandemic, would allow them to have some degree of confidence. So if they were required to go back and work in an intensive care environment, they would at least have some familiarity with what had been happening in terms of basic intensive care management.
And that's something which you think should be maintained?
Absolutely. We have been clear from the publication of the initial enhanced care report in, I think it was May 2020, and then the subsequent report that we wrote with the Centre for Perioperative Care around how you provide enhanced care services for perioperative surgical patients, that the benefit of this is great for the patient because it provides them a secure pathway for elective surgery, but it's also beneficial for staff, both medical and nursing and allied health professionals, because it keeps a degree of skills up that were perhaps not as recent at the start of the pandemic.
What about from the perspective of the intensivists, having to work with staff who were not ordinarily trained in intensive care? What was the experience like from their perspective?
So we had a survey from the Faculty of Intensive Care Medicine towards the end of 2020 of our fellows and members around the experiences, and many of those responses included positive comments about the benefits of working with anaesthetic colleagues, getting a perspective that allowed a greater mutual understanding of our roles, which inevitably would have a positive impact on patient care. I think from a nursing perspective, and this is completely different perspective, the pressure on nursing staff of working with individuals who don't have those skills is very different, and the concerns around supervising individuals who haven't got basic intensive care nursing skills was a considerable burden for our nursing colleagues. I'm aware of that.
The inquiry has heard a lot about intensive care ratios being stretched and nursing ratios, and the fact that they should normally be 1-to-1, and at times they were, I think, sometimes as high as 1-to-6. Is that something that you're aware of?
Yes.
Is that, when talking about those ratios of 1-to-6, does that include staff who may not have been trained in intensive care, or is that only with respect to trained intensive care nurses?
So my understanding of those relaxation of the ratios was one trained intensive care nurse to one patient. The 1-to-4 ratio or the 1-to-6 ratio was around one trained intensive care nurse looking after 6 patients with support of additional staff who were not trained in intensive care medicine. So it was not understood to be one nurse alone looking after 6 patients. It was one trained nurse supervising a number of other individuals who had a variable degree of skills in delivering care for the patients.
In some ways, one can see obviously how the additional support was helpful, but having to supervise untrained staff, in addition to looking after patients at stretched ratios, did that carry an additional burden for some of those intensive care nurses?
I'm aware that it did carry a considerable psychological burden for a number of intensive care nurses. Intensive care nurses are highly trained individuals who have a high degree of responsibility, who work very closely with medical staff in very close-knit teams. And when that normal working practice is disrupted, you have a number of patients who are very unwell, then that does add to the burden and obviously the concern around being able to do your job to the level that you expect to do your job.
Turning then to a new topic, the decision to suspend elective care, elective surgery, I should say. This is a decision which I would imagine had quite a significant impact on anaesthetists, is that right?
Can I ask you to clarify?
Is it not right that within the context of surgery, an anaesthetist has a very considerable role, particularly in the context of suspending elective surgery? Would that not have resulted in a number of anaesthetists who would ordinarily have been working in elective care moved out of that area? Yes,
so there were 2 reasons why elective care was impacted. One of which is that some of the anaesthetists, both those in training and at consultant and SAS doctor level, were required to come and work in intensive care units at various times. There was also an impact in the removal of some of those trainees from service. So some of the consultants that would have been doing elective surgery were then required to cover services out of hours and provide a more consultant-led delivery of service than might ordinarily have been the case. So there were just fewer anaesthetists around to do the elective work. And then the final impact was around being able to develop COVID-secure pathways for patients that were needing to have procedures. So all of those if you like, conditions impacted on the ability to provide elective operating.
Yes, you talk about this in your statement. You talk about the clinical realities, some of which you've just touched on, including the availability of anaesthetists and also availability of theatre space, because some areas of hospitals have been repurposed, infection prevention and control measures, some of which you were just touching on in terms of pathways. Is it the case then that practically, even had the decision not to pause elective surgery been taken, it would have been very difficult to have continued with elective surgery in any event?
I think what we know from our surveys and experience at the time is it was very variable, and it very much depended on local arrangements and local facilities. So where you had an intensive care service that was well resourced, that you were able to provide a COVID secure pathway, perhaps your estate was amenable to being able to provide a COVID secure pathway for patients. That made doing some elective surgery much easier, and perhaps the larger hospitals had the ability to do that because they had more flexibility than some of the smaller hospitals had. So it was very location dependent and perhaps also time dependent, because it was not a consistent pattern throughout the period of the pandemic.
Did your organisation support the decision to suspend elective surgery in March 2020, which it was taken in various different guises across all 4 nations?
I think there was an understanding that at that period it was going to be necessary in order to ensure that we had sufficient individuals who were able to respond to that first wave of the pandemic, because we didn't know at that point how severe it was going to be. But our organisations were also involved in producing guidance to help local trusts and services identify how they could safely reintroduce elective operating at the earliest point. So we were also very keen to support our members and our services to make sure that patients were brought back in for surgery as soon as we could safely do so.
The inquiry has instructed experts, Professor Andrew Metcalfe and Miss Chloe Scott, to examine the impact of the pandemic upon those requiring hip replacements. I'd just like to bring up a passage from their report. It's INQ 304744262, paragraph 48. And it says here, given both the anticipated impact of the pandemic on the healthcare service and the uncertain risks for patients undergoing surgery, the decision to suspend elective surgery in March 2020 and in many trusts in December 2020 or January 2021 was unavoidable in the circumstances. However, the delays in many hospitals and regions in restarting elective surgery and the variation around the country reflected a variability in both resource and decision making that had a major negative impact on the lives of hundreds of thousands of people across the country and continues to do so. Do you agree with that broad statement?
Yes, and if I can add some additional context. So we went into the pandemic with about 15% too few anaesthetists. We knew we also had too few intensivists as well, and that had an impact on our ability to provide support to elective operating. We also had early research evidence that suggested that patients shouldn't have surgery within 7 weeks of having COVID, so that impacted on decision making and planning around when an individual came in for surgery. And we also know that at times of pressure like that early first wave and then over the winter of 2020-21, again, there was not the space or the individuals who were able to re-escalate elective surgery back to where it was. So we started with a low level of resource, both human and to a certain extent estate, and then when we were under pressure, we were limited in how we could respond.
The issue then is what you and the experts instructed by the inquiry have summarised there, really one of restarting elective care rather than the initial logic behind the initial decision. The inquiry has heard the phrase postcode lottery used occasionally. Is that a phrase that fairly encapsulates the fact that there was significant geographical variability in terms of the ability to provide patients with elective surgery?
So if I could go back to the provision of intensive care beds and facilities, we know that across all 4 nations of the UK, that at baseline was not equal, and we have health inequalities. So going back to pre-pandemic, Wales and Northern Ireland had intensive care bed occupancy that was over 95%. Even within that 10 per 100,000 figure quoted for England, there were certain parts of England, namely London, that had more intensive care beds than other parts of the country. If the pandemic was then impacting not equally on all areas of the country at the same time, you will then have a situation where certain services will be in a better position to restart than others.
So there's an obvious link then between critical care capacity and the ability to perform elective care.
If we had sufficient critical care capacity, we would not have required as much support from our anaesthetic colleagues as we did. And if we had the ability to develop some of these COVID secure pathways like enhanced care so that we could have additional alternatives, we would have been able to perhaps respond differently.
And also perhaps not needed to, we wouldn't have needed to suspend elective care as well, because you wouldn't have needed to redeploy those anaesthetists. Does that follow or not?
I think it's difficult to be certain about that, because we know that particularly over the winter of December 2020, January 2021, there was extreme pressure on the NHS in general. And again, the complexities of keeping patients without COVID coming for elective surgery safe and protected from areas of the hospital where there were large numbers of patients with COVID, that ability wasn't there.
Thank you very much, Dr. Bryden. Melody, that's all I ask.
Thank you very much, Mr. Farman. Ms. McDermott.
Dr. Bryden, today I'll be asking questions on behalf of the UK COVID bereaved Families for Justice and the Northern Ireland COVID bereaved Families for Justice. And Mr. Fireman has taken you through the fringes of the question I'd like to ask you in terms of capacity, and separately working with intensivists and the ratios around that. But the topic I want to focus on is the capacity in terms of staffing levels. And set out within your witness statement at paragraph 96, you state that during the pandemic, due to the need to considerably increase the number of critical care beds, there were not enough trained critical care staff to call upon to meet the expected staffing standards. Now, the Faculty of Intensive Care Medicine carried out a survey during November 2020, and in response to the question, do you think any increase in ICU footprint has been adequately staffed, 82% of the respondents said no. In your experience and that of your members, was this indicative of a problem during the pandemic, that physical capacity in ICUs was not matched by adequate staff members?
So again, before the pandemic, the faculty had conducted a series of workforce engagements around the UK, and we had also data that were very clearly indicating that we did not have adequate capacity in critical care, and that there were certain areas of the UK that were more severely impacted than others. The other important message that we made very, very clear right from the beginning was capacity was not just around the physical space and the provision of a bed or a piece of equipment. It was around the human resource, if you like, the ability to care for and treat an individual. And again, we had identified the fact that we didn't have sufficient numbers of critical care staff who had been adequately trained at the start of the pandemic. So during the pandemic, when there were increased numbers of patients presenting, we had that situation of even more pressure and therefore needing additional support in order to be able to do what was asked of us.
And that's somewhat of a separate topic in terms of, you'd mentioned in your evidence about Wales and Northern Ireland having bed space of already ICUs over 95%. That's different to then actually having the staff, isn't that correct?
Yes, because it will depend on whether or not there may be a physical bed space, but if there's not the contracted funding to provide the staff to look after the bed, then it's not an operational bed. It doesn't exist in terms of a bed that you can safely admit a patient into.
Thank you. Considering your statement in the round from the perspective of those which I represent from Northern Ireland, your statement contains very limited reference to data emanating from Northern Ireland. Now, I don't expect you to know this offhand, but on the 11th of October 2022, the Royal College of Anaesthetists Northern Ireland held a board meeting. And at that meeting, it was certainly anticipated that the Northern Ireland Royal College of Anaesthetists would contribute to this inquiry. There was then a debate as to whether it would partner with the Academy of Medical Royal Colleagues or whether it would stand alone as an organisation. With a reluctance to the latter because of cost implications. I'm just wondering, do you know if the Royal College of Anaesthetists Northern Ireland did make an application to stand alone as a body?
So if I can provide a point of clarification, the Royal College of Anaesthetists is based in London but is a four-nation body, so it has boards, and one of those boards is in Northern Ireland. So its Northern Ireland board impacts and advises the Royal College of Anaesthetists as a whole in its entirety. So on that basis, it's not an independent organisation, but it is part of the Royal College of Anaesthetists and does advise and gives information.
Thank you for that clarification. I'm just wondering, mindful of what it said in the minutes, it had suggested it would go in potentially as a standalone body, and I'm wondering, do you know whether or not the Northern Ireland branch of the Royal College of Anaesthetists had applied to go in as a standalone body?
I don't, but I can find that out for you.
And if the Northern Ireland College and the Royal College of Anaesthetists Northern Ireland branch had worked with you, did they liaise with you in providing your statement or information to this inquiry?
So the information that is in my statement is from all three organisations, and my understanding is that the Royal College of Anaesthetists has drawn its information from its wider college membership and information that it held at the time.
So then, looking at your statement specifically, do you accept that there's very little or very limited reference to data in Northern Ireland?
I would accept that, yes.
I'm grateful. In a similar vein, your statement makes no mention of any meetings or engagement between the Northern Ireland branch of your body with either the Chief Medical Officer for Northern Ireland or the Medical Directors for the Health and Social Care Trust in Northern Ireland during the pandemic. Are you aware that any such engagement ever took place?
Again, I'm not directly aware of that, but I can find out for you.
Okay. If you are to provide that information to the inquiry, perhaps you could follow that up with what the reasons were if the answer is in the negative, if they didn't engage with the CMO and the medical directors.
Yes.
Those are my questions. I'm very grateful, my lady.
Thank you, Ms McDermott. Ms Katz-Jones.
Dr. Bryden, I ask questions on behalf of the COVID Bereaved Families for Justice Cymru group, or Wales. And I'd like to ask you first of all about communication with Wales and Welsh bodies. Other than the Royal College of Anaesthetists Welsh Board having representation on the Academy of Medical Royal Colleges Wales, which met with the CMO every 2 or 3 weeks, as you outlined for us at the beginning of your evidence, was there any other engagement between the Royal College of Anaesthetists, the Faculty of Intensive Care Medicine and or the Association of Anaesthetists with either Welsh Government or with Public Health Wales that you're aware of?
So prior to the pandemic, the Faculty of Intensive Care Medicine conducted a workforce engagement event in Wales and also met with the Health Minister at the time, who then became the First Minister. So we had engaged prior to the pandemic. During the pandemic, one of the board members of the Faculty of Intensive Care Medicine was also a member of the Academy of Medical Royal Colleges in Wales, and was also, as I understand it, in engaging with the Chief Medical Officer for Wales.
And within that engagement, are you aware what issues, if any, were raised?
I would not be aware of specific issues in relation to Wales, but again, I can find that out for you. But my understanding is that a lot of the issues in relation to Wales were very similar to the issues in relation to the rest of the UK, in addition to, as I've already highlighted, the sort of very poor provision of intensive care beds in Wales that was known about prior to the pandemic. So the lack of resource and the impact that was having on Wales.
Thank you, Doctor. That brings me on to my next topic. In paragraph 105 of your witness statement, you set out for the inquiry, and I'll read it for you, Doctor. The highest level recommended for intensive care bed fill rate for safe and efficient patient care is 85%. However, ICUs were running above this pre-COVID-19, making the UK woefully underprepared to cope with a large additional demand for intensive care. And then you go on in paragraph 106 to set out some survey data from the FICM taken in 2018, which showed the bed fill rate in Wales was estimated to be at least 95% in 2018. Therefore, my question is this: in addition to being woefully underprepared, what would the impact of that bed fill rate been in Wales at the time the pandemic hit?
So we have a situation where you have inadequate numbers of staff who are able to respond, and you also don't have the facility, the estate, in order to take increased numbers of patients, and it does impact in terms of the ability to manage patients within the footprint of an intensive care service. So we know that when there's a high bed occupancy, it does impact on how we deliver care to patients.
Thank you, Doctor.
Thank you, Ms Jones. Ms Peacock. Ms Peacock's behind you, but if you, by all means, look at Ms Peacock while she answers the question. If you can make sure you get your answer into the microphone, I'd be really grateful.
Okay.
Good afternoon. I ask questions on behalf of the Trades Union Congress. My questions focus on the Nightingale hospitals which were constructed during the pandemic. In your witness statement, you explain that the Faculty of Intensive Care Medicine was consulted on that project to construct Nightingale hospitals. That's at paragraph 39 of your statement. You speak of initial meetings which focused on potential locations for the Nightingale hospitals, and later meetings which focused on guidelines, patient safety and training. At what stage in the pandemic did these meetings take place? Are you able to identify a broad time period?
So my understanding is that was effectively around the first wave of the pandemic, and some of the conversations were particularly around providing training materials and very rapid upskilling for staff that would be working in the Nightingale hospitals. We were supplied with information from some of the local London hospitals around the information that, or the materials that they were using for the, or proposing to use for the London Nightingales, and we were then advising and trying to identify how they could be made more generic for the Nightingales. In addition, liaising with Health Education England at that time around how we could recognise the skills of staff that may be working in those units, both in terms of pre-existing skills and then recognising any skills that were required subsequently to enable staff to effectively passport to say that they had worked in an area and could transfer to work in another area because they had the appropriate skill set.
And you go on in your statement at paragraph 40 to explain that the FICM pointed out that workforce would be a major issue as experienced clinicians would be required to staff the new hospitals, which would denude existing NHS hospitals and potentially make the project unviable. And just to put that into some context, the Nightingale hospitals were large, with maximum bed capacities in the hundreds and thousands. And you set out in your witness statement and in your evidence today that pre-pandemic staffing levels were very overstretched. Where existing IC units were already struggling to maintain appropriate staffing levels, should it not have been clear at the outset to the teams establishing very large temporary hospitals that staffing provision would be a significant barrier?
So I think we were clear from the very beginning that we had insufficient critical care staff to if you like, as a baseline going into the pandemic. And throughout, we were very, very clear that provision of an intensive care bed was not just around the bed and the equipment, it was the human resource. So it was around having the individuals who could care for patients that were in those beds. And that was a consistent view that we took both in terms of public information and messaging and also in terms of private messaging, in terms of meetings that we were having around saying that it was around identifying a resource that was more than a physical one.
And were you given any response to you've said that it was from a very early stage, your initial advice that staffing would potentially render the Nightingale project unviable? Was any response provided to you?
So again, just to clarify, I am not aware of any specific advice that we gave that said the Nightingale project was unviable. Our view was very much around making clear what the criteria would need to be in order to staff such a facility safely and being very clear about where the staff would come from. So we were not making comments around the viability or otherwise. It was being very clear what was needed in order to operate those facilities.
But your evidence in your statement, if I'm correct, is that the staffing levels available at that time would potentially render the project unviable. That's at paragraph 40.
Yes, so our view very much was around we could not staff the Nightingale hospitals and continue to run existing critical care units because the staff were needed at the existing critical care units. So the only way that we could consider would be moving staff to the Nightingale hospitals wholesale. Our understanding, or my understanding, is that the Nightingales that operated as an intensive care unit were effectively the London Nightingale and the others did not. And again, feedback from colleagues was around the fact that they didn't have spare staff to go and work in the Nightingale. So that was often a rate limiting step in terms of providing support to the Nightingales.
Do you think at its heart, and this is my final question, the establishment of the Nightingales in such large numbers with the staffing issues you've identified reflected a misunderstanding that an intensive care bed is much more than just a piece of equipment that can be dropped into a new temporary hospital, but it requires an ecosystem of highly trained staff around it?
So again, I think we have been inconsistent from before the pandemic and across all 4 nations of the UK and throughout the pandemic that the critical care service that existed prior to the pandemic was already under pressure, and we were consistent throughout the pandemic that it was the human resource that was going to be the rate limiting step, and that is why we needed the support of colleagues from the rest of the hospital and the impact that that had on patient care in the rest of the hospital because those staff members were not available to provide the care and treatment that they needed.
Well, thank you. I've used up my time, so I'll leave it there. I'm grateful, my lady.
Thank you, Ms Peacock. Those are all the questions we have for you, Dr. Bryden. Thank you very much indeed for your help. Very grateful. And I shall return at 10 o'clock tomorrow.
All right.